Hi, thank you for having me here. My name is Fernando Fácio, and I'm the president of Latin American Society for Sexual Medicine. Welcome to this webinar sponsored by ISSM. On behalf of the Latin American Society of Sexual Medicine, I would like to thank Dr. Gerald Brock, the president of International Society for Sexual Medicine, the members of the Education Committee, and our distinguished speakers. Next slide. Today, this webinar has a simultaneous translation. Please note that this webinar is in English and we have translated for English to Portuguese and English to Spanish. Next. And you can use the subtitles and translations. ISSM webinar now have options for add automatically the subtitles include translations. Next, please. And if you have questions, please, you can use it, the Q and answers and Q&A for your questions. And I would like to invite you to our World Meeting on Sexual Medicine that will be held in Rio de Janeiro in September 2006-2009. Please join us in this wonderful event. Now, I'd like to introduce Dr. Leonardo Seligra. Seligra is an associate professor at the ABC School of Medicine in São Paulo, Brazil. He is a member of several societies, such as AUA, European Society of Urology, ISSM, and he is a member at large of Latin American Society for Sexual Medicine. Thank you. Enjoy this webinar, and Leonardo, it's with you now.
Thank you, Fernando. It's my pleasure to be here with you today. And I'd like to thanks about the invitation to moderate this great webinar with such great panelists. In the issue that's very important for us, the testosterone replacement regarding sexuality and prostate cancer, and such great names here to join us. So thank you very much for this. I'd like to show you how about is our program to be. So we'll have two first panelists talking about testosterone and prostate cancer. That will be Landon Trost. Testosterone and sexual function. That will be Seligra. And after that, we join everybody in a roundtable discussion with Mohikera, Juan and Dino, if he can show, because he got an issue to be here, and Adrian Hayes from Peru. So first of all, I'd like to introduce for you our first panelist, Landon Trost. Everybody know him, but I try to give him a name. He's affiliate faculty at Brigham Young University. He's specializing in vasectomy reversals, Peyronie's disease, and male infertility. Nowadays, he's the director of the Male Fertility and Peyronie's Clinic and president of the Charity Cure PG, our actual editor from Sexual Medicine Journal. So thank you, Landon, to be here and talk about testosterone and prostate cancer.
Well, thank you very much, Leonardo, and thank you, Fernando, for the invitation. It's certainly my pleasure to be with you, and I appreciate all those who are joining us as well. As you may notice, we'll be saying next, with each of the slides. So apologize in advance for those watching on it. But very pleased to be able to speak on the topic of testosterone and prostate cancer. This is certainly one of the most controversial, and it's been the most controversial, topics of testosterone therapy for probably 10 to 20 years or so. So, grateful to be able to present there. Next slide. By way of disclosure, so I'm a member of the AUA Testosterone Guideline Panel, but I won't be acting on behalf of the AUA Guideline Panel here. And I do have research grants from Endopharmaceuticals that does have a testosterone product, but I don't receive any individual funds from them, any PI funds or anything at all. It's just purely for the research side of it. Next slide. Okay, so we wanted to start, basically, we only have 15 minutes. So I'm going to try to nail down the two kind of key topics that we wanted to get to. And I broke it down into two cases. For the first one, next slide, this is a 55-year-old African-American male, PSA 3, family history of prostate cancer, low testosterone. and has multiple low T symptoms. So next, the key thing this is showing is what is the risk of developing prostate cancer? So he's got high risk features. He's got several different things that would say, all right, this guy is at risk of developing prostate cancer. If we start him on testosterone, is he going to increase his risk there? Next. And again, just summarizes that, all right, case number 1, testosterone therapy and the risk of developing prostate cancer. Next slide. So when you put together a guideline with the AUA, they basically summarize all of the randomized controlled data, and they do an analysis for you as to whether or not the result was seen in the specific topic you're looking at. And so in this case, there were 28 randomized controlled trials, all had total testosterone below 350, and they showed that your PSA does indeed go up a little bit. So it went up by 0.2 in this particular analysis of the randomized controlled trials. Next slide. But interestingly, there was no increased risk of a PSA greater than 4. So that's, depending on age and things like that, the threshold for you say, all right, this is when we're going to consider biopsying and so on. But even though the PSA did go up, we didn't see a higher rate of elevated PSAs with it. Next slide. This is one of the more commonly cited meta-analyses. Now, it's kind of old now, but this was a meta-analysis of 4 randomized controlled trials, specifically looking at the risk of prostate cancer. And they too showed that even though you increased the rate of men who got prostate biopsies, you didn't see a higher rate of prostate cancer developed here. And that again is consistent with multiple other meta-analyses as well. Next slide. This is the largest randomized controlled trial that has ever been done in testosterone therapy, and likely will ever be done in testosterone therapy. And we're grateful to have Mo Kira with us on the panel here, who was part of this study. So over 5,000 men aged 45 to 50, testosterone, total testosterone less than 300, treated with testosterone gel for 22 months here or so. The key thing here, you can see just like the AUA guideline, they went up by 0.2, so identical to what was found in the AUA guideline compared to placebo, and that was statistically significant. So we did see a statistically significant, but essentially irrelevant rise in PSA. But again, there was not a higher rate of prostate cancer in this study. So 12 events versus 11 events in this particular study. Next slide. And the T4DM study, another major large study that came out in the last couple of years, so about 1,000 men. These were diabetic or pre-diabetic, treated with a much higher dose of testosterone. So this group was much more of a true contemporary dosage of testosterone, and showed again prostate cancer 4 versus 5, so not significant, but again a higher rate of PSA. So in this case, a rise of greater than 0.75. 23 versus 19%, not a huge difference, but it was statistically significant. And again, this was 2 years, which is really important from a testosterone therapy standpoint. So next slide. This leads to, AUA guideline statement number 17, which says that clinicians should inform patients of the absence of evidence linking testosterone therapy to the development of prostate cancer. So it's kind of a clumsy, wording there. But basically, there's an absence of evidence linking an increased rate of prostate cancer in men getting testosterone therapy. Next slide. Now, I say all that, that's all the right answer. But when you look at it, testosterone therapy in prostate cancer is far, far more complicated than just that. And all of the studies we've looked at so far are really, really short term when you consider it in the context of prostate cancer, which takes many, many years to really show anything. Next slide. There's a couple of key concepts, and again, we're real limited on the amount of time I can go into this, so I'm just going to touch on these real high level. But just to show this is a complicated topic, we don't know the impact of testosterone on prostate cancer in reality. So if we look at hormones and pathophysiology here, next slide. One of the core concepts with testosterone and prostate cancer is this concept of testosterone and dihydrotestosterone. Now, these cause a growth in the prostate itself, and it results in cell division and PSA production. Now, cell division, of course, is one key step in the development of any sort of cancer. Now, testosterone increases 5-alpha reductase, and in particular, isoenzyme 1 is responsible for this increase. And that further increases the translation from testosterone to dihydrotestosterone. Next slide. And you can see in the pop-up here that finasteride and dutasteride, they each impact a different enzyme or isoenzyme here. So you have type 2 isoenzyme is impacted with finasteride, whereas dutasteride is both type 1 and type 2. Next slide. Now, this is important because in the prostate cancer prevention trial, one of the most highly cited trials in urology, finasteride versus placebo for 7 years, there was a 25% reduction in prostate cancer, but Gleason 7 to 10 was much more common in men who received finasteride. So again, if you start messing with the different isoenzymes, we start to see that you start to impact the differential production of different prostate cancers. And the reduced trial, similar concept, so dutasteride versus placebo for 4 years. Again, big numbers, 6,700 men here. There was a 23% reduction. However, during years 3 to 4, dutasteride had 12 tumors in the Gleason 8 to 10. So again, this higher risk Gleason scores versus 1 with placebo. So we do see that if you mess with the hormones, in particular the different isoenzymes, you can impact the differential breakdown of prostate cancer. Next slide. So then it goes a little bit further because dihydrotestosterone can enhance the transactivation of androgen receptor genes, which stimulates mutations in androgen receptor. So now this is very rare in the early phases of prostate cancer, but it becomes much more commonly, or it occurs much more commonly in more advanced prostate cancer. So in particular, castrate-resistant prostate cancer. So, and again, I just highlight this to show that this is far more complicated than just something real simple, because on the next slide, you can see that all of us have seen or heard this slide or this concept, which is this saturation hypothesis. And this is real commonly cited to say, hey, if you raise the testosterone beyond a certain level, it has no additional impact on the prostate. It's already fully saturated. It's a great concept, but if you actually pull the original data, so I'm going to pull the Mark study here, which was the original one that was later popularized by Morgenthaler and colleagues. If you go to the next slide, you can see that in the study, it was 40 men. It was a randomized trial looking at testosterone versus placebo in benign prostates. So not prostate cancer men, but benign prostates. Now, the results were there was a 70% increase in intraprostatic testosterone in the testosterone therapy men, but negligible increase in dihydrotestosterone. But if you just read the abstract, it says the median prostate tissue levels of testosterone and DHT did not change in the testosterone group. Well, it's not true. It just wasn't powered enough to really know if that's the case or not. So on the next slide, that's real commonly known as a type 2 statistical error, where you claim that something is negative, even though you're not powered enough to truly show if something's negative. Now, interestingly, in the study, if you look, and I've highlighted it in red on the bottom there, the dihydrotestosterone tissue levels were actually 2-fold higher in men who received testosterone. And again, this study is highly cited of people saying that it did not raise, the intraprostatic levels of testosterone or anything along those lines, but indeed it did. And if you look again at the androgen receptor, which again earlier I showed is real critical to developing a prostate cancer, if you click next, you'll see that it's actually, and next one more time, it's actually a 64-fold increase in the levels of men who receive testosterone versus placebo. So even in benign prostates in men who are fully saturated on the testosterone side of things, we do see higher rates of these early indicators of development of prostate cancer, which are present. Next slide. So all of this is just to say that if you add testosterone to men with a median baseline of 280, you did see an increase in prostatic hormone levels and androgen receptor. Next slide. So, and again, this is far more complicated. There's multiple co-regulators with androgen receptors, and both testosterone and dihydrotestosterone can activate. And there's many downstream impacts of this. So HER2, we all know, is associated with multiple malignancies, and this is one of the downstream effectors of testosterone. Next slide. And it's even more complicated because estradiol and estrogens contribute to prostate cancer development. And when you look at men with prostate cancer, in particular metastatic disease, they have 30-fold higher rates of aromatase, which are present, which can have impacts. Even though your testosterone levels may stay stable, you get a much higher conversion of testosterone to estradiol and other downstream, and their downstream effects as well. Next slide. So again, don't have enough time. I just touched on just one point here, which is the hormones as well as the androgen resistance, but didn't go into the heterogeneous cell populations, didn't talk about the microenvironment and the micrometastatic disease. There's a lot of factors which say that we just don't know the impacts of testosterone in prostate cancer. Next slide. So that's scenario one. Does it cause prostate cancer? And again, there's an absence of evidence saying that it causes prostate cancer. Case number two, if you click next, now we're going to look at the same 55-year-old African-American male, but he has Gleason 6 on active surveillance. He's ultimately undergoes a prostatectomy for Gleason 4+3 T3A disease. PSA is undetectable at 6 months, low testosterone. He's got multiple symptoms. Click next, please. So this is now treated or in situ prostate cancer. And next. And the question is, do you give testosterone therapy in this group? So we've already talked about the risk of developing prostate cancer. Now in men who have established prostate cancer, which has been treated or which is in situ, are they appropriate candidates for testosterone therapy? And next slide, please. So this is only some of the data that's out there. You can see there's many studies which have looked at this and said it's very safe. both in untreated prostate cancer as well as in treated prostate cancer, they have not shown a higher rate of developing prostate cancer in men who are treated with testosterone in these groups. Now, one of the issues here, though, is you can see the numbers are very small. So you've got 13 men, 28, 7, 10, 31, 103, 5, 20, and so on. So we don't really have high rates of, or, real big numbers here where we can say that we can, confirm with confidence that there is no increased risk of developing prostate cancer in these groups. Next slide. Now, this is really important because, as you know, with prostate cancer, it takes a long time and huge numbers to see differences. So even in men undergoing a prostatectomy, on the top, you can see these low-risk men, you don't see a difference at 9 years. Now, these are men who are treated with a gold standard therapy to cure prostate cancer, and we don't see a difference in splitting in that group. Intermediate risk, you don't start to see a survival difference till 18 years, and even high-risk men, so Gleason 8s, 9s, 10s, you don't see a difference until around 7 to 8 years, where even a gold standard therapy, you don't see a split. Click next, please. So you can see one of the key issues here is it takes a lot of time to identify differences in any sort of therapy. So all of those studies we've mentioned previously, you're looking 1 to 2 years, which just isn't enough time to detect a difference, period. Next slide. So there was a good power analysis done years ago by Califf and colleagues, and to my knowledge, there hasn't been a better one done since then, but they showed that in order to see a 20% difference or 20% increase in prostate cancer, it would take 86,000 men for 1 year to be able to detect that difference. And to give you an idea, the largest randomized controlled trial performed to date was 5,200 men, or roughly 2 years. I put a year here, but 2 years. And again, 20% is a huge difference. So that's not talking about a 5% difference, but it would take 86,000 men per year to be able to detect a 20% difference on it. So basically, we just don't have the data to show one way or another. Next slide, and we're going to click through these ones a little fast. So if you put it all together, click again and again and again, you can see that the total here that we have roughly to date is in the order of 2,000 to 3,000 or so, which are saying, this is they're essentially safe in these men to undergo testosterone therapy in men with prostate cancer. But if you click next, the number that you actually truly need, and click one more time, is huge. So the total amount of data we have to date versus the amount that we need to prove safety of testosterone therapy is hugely different, hugely discrepant. Next slide. In other words, we're never going to know for sure if it's safe in this group. And because of that, for the AUA guideline statement number 18, we said patients with testosterone deficiency and a history of prostate cancer should be informed there is inadequate evidence to quantify the risk to benefit ratio of testosterone therapy. Next slide. So key take homes here is testosterone therapy does increase PSA slightly, but it doesn't increase the risk of an elevated PSA necessarily. And there's no consistent evidence that testosterone therapy causes de novo prostate cancer, but technically testosterone does cause prostate cancer because, eunuchs, men who are androgen receptor deficient, women, things like that, don't get prostate cancer. So it clearly leads to it, but does it lead to development of new prostate cancer? That we don't know. And that's also true with in situ prostate cancer or treated prostate cancer. We just don't know if it's safe, and we'll never have a study large enough to truly know the impact of testosterone on prostate cancer development or progression. And with that, I thank you very much for your time.
Thank you, Landon. It was a very extensive review about testosterone prostate cancer. And we have a couple of questions here, but I think we can keep it for the roundtable discussion, and then you join us about that. And thank you very much again. And I'll try to get to the next panelists here. I'll invite Dr. Sidney Glina. Sidney Glina is also very well known from everybody here. He's actually the head of the Division of Urology in Centro Universitário UFM ABC here in Brazil, past president of ISSM, past president of SBU, Sociedade Brasileira de Urologia, past president of SLAMS, a great master of all of us in andrology, and emeritus editor in the International Brazilian Journal here in Brazil also. So Dr. Sidney, thank you to be here with us. And the panel will now be hearing about testosterone and sexual function, most of ED. Thank you very much.
Good evening, good night, good morning. I don't know. There is a worldwide webinar, so we have people from all over the world. I thank to SLAMS for the invitation, for the ISSM for the kind invitation. I was asked to talk about testosterone and sexual function, but I will focus more on erectile dysfunction. Next, please. Those are my conflict of interest for this lecture. Next. What can a decrease of testosterone levels impact of men's sexuality? We know you have a decrease of sexual desire, the sexual libido. There is a decrease in the quality of erections and the appearance of erectile dysfunction. It has been reported that you can have a delayed ejaculation, although it is not a very common finding in our practice. There is a decrease in the ejaculatory volume, and the patient who has a testicular atrophy used to have a decrease of testosterone, and the patient who gets testosterone has also a decrease in testicular size. Next, please. This is now I think it's almost a classical paper. They studied the increase of prevalence of symptoms of the decrease of serum levels of testosterone. It was a great number of men. So they are looking when the testosterone starts to decrease, what's happened first. You can see that the first symptom is loss of libido, obesity, depression, sleep disorders, and the last one is erectile dysfunction. To a man to have a erectile dysfunction because of a decrease of testosterone, the level of testosterone needs to be very low. In the vast majority of offices all over the world, if a man comes with claiming of erectile dysfunction, he has a low or a borderline level of testosterone, he will get testosterone for sure. And you know that the erectile dysfunction is the last symptom when the testosterone decreased. Next, please. It's another paper from Andre Guay. It's very interesting because they studied men with low testosterone. You can see that the normal range for this study was between 11 and 35 nanograms per deciliter, and they stratify the level of testosterone and the percentage they call successful sexual activity. They are talking about erections, and you can see that even when the testosterone is low, it's below 10. Almost most men has a normal sexual activity. When it was between 77 and 8, half of the men still gets an erection. Only when testosterone was below 7, no man got an erection. So again, to have erectile dysfunction because of testosterone level, the level of testosterone should be very, very low. Next. This is one of the reports Landon told about this study, the Traverse study. It was probably the main study on testosterone replacement. It's almost 5,000 men. 1,200 men were enrolled in the sexual function study, men with low libido. Half of them received testosterone gel and half placebo, and the results were very interesting. The replacement of testosterone was associated with significantly greater improvement in sexual activity than placebo. Okay, testosterone replacement improves sexual activity, but the TRT improved hypogonadal symptoms and sexual desire, but not erectile function, again, compared with placebo. Okay, again, testosterone by itself does not restore erectile function. Next. This is an old study, but it's very interesting. They studied the nocturnal penile tumescence and the erectile response to visual erectile stimuli. It was measured using rigid scan in 9 hypogonadal men at the baseline after 3 months after testosterone replacement, and the same assessment were performed in 12 eugonadal men, and the number of satisfactory nocturnal erections were lower in the hypogonadal men than in controls, and increased significantly with testosterone replacement. But the erectile response to visual sexual stimulation did not differ between hypogonadal men and controls, and did not increase with androgen replacement. Next, please. So probably decreased testosterone impacts in the nocturnal erections, but not in erotic erections. So it seems that the testosterone level is very important for the nocturnal erection, but a man with low testosterone still can respond with erection to a erotic stimuli. Next. It's another interesting study. They studied 10 healthy young volunteers, below 35 years old, and they noticed that the men using LHRH agonists had a significant decline in the duration of nocturnal erections at week 4, and a significant reduction, almost abolishment, in the weeks 8 and 12. So again, testosterone is very important for nocturnal erections. Next. There's a very interesting paper by Trash. They castrate rats, and they study the histology of the corpora cavernosa. You can see in the first, in the A picture, is the control. You can see that the smooth muscle, it's very it's normal. There is no any pathology in the smooth muscle. 2 weeks after the chemical castration, they use a LHRH agonist. You can see that there is a decrease in the smooth muscle, and after 8 weeks, there are almost no smooth muscle. Again, showing that testosterone has an important role in the maintenance of the histology of the corpora cavernosa. Next, please. Again, it's another paper by Sabshik. They show that when they in rats, again, castration causes apoptosis of the smooth muscle cells, and the testosterone replacement promotes the reestablishment of the smooth muscle. Next, please. And testosterone, the relation between testosterone and erection, it seems that testosterone regulates the synthesis and maintains an adequate supply of nitric oxide, and it does that stimulating the oxygen nitrosynthetase. Next, please. We can see here that testosterone acts on oxygen nitrosynthetase, and it will keep the quantity of the nitric oxide inside the corpora cavernosa. Next. Another place where testosterone is important is on the response to PD5 inhibitors. It's when a man comes to us with a patient who is a non-responder to PD5 inhibitor, or it was a responder, and now the response is worse. We need to check the testosterone levels. Next. This is a paper. They studied the expression the expression of PD5 in rats corpus cavernosum, and we can see the rat bar. We can see that there was almost a diminution of the response on the animals castrate, and it doesn't change too much when you add tadalafil. And in the blue one, you can see that if you castrate and you replace testosterone and you give tadalafil, you increase the response. Next. And here you can see a paper by Aversa. They show the effects of testosterone therapy on response to sildenafil in patients with erectile dysfunction. Previously non-responder. You can see the IEF baseline on the left. When you add sildenafil and plus placebo, the IEF does not increase. And when you give the sildenafil and testosterone, there was a increase on IF. So a sign of testosterone decrease is that no response or a worsened response to PD-5 inhibitors. Next. So it's important to remember that erectile dysfunction only occurs with very low testosterone levels. Testosterone replacement therapy in hypogonadal men with ED improves erectile function and response to PD-5 inhibitor. And if there is no response to PD-5 inhibitor, check testosterone levels for the possibility of hypogonadism. And TRT improved other parameters of sexual function, mainly the sexual desire and the ejaculatory volume. Thank you very much for your time.
So thank you, Dr. Glina, for the excellent presentation, and both panelists give us such a good support to our next time roundtable discussion. So I'd like to introduce you and ask to join us the next panelist presentations here. And Dr. Mohit Khera, also well known of everybody here. He is from medical school at San Antonio and Baylor College of Medicine, and that's the actual president of SMSNA. So thank you to be with you here, Dr. Mohit. And asking to join us Juan Andino. Andino is our new generation neurologist from SMSNA, and he's also with big collaboration with SLAMS and many good other talks. Thank you, Juan, for being with us here. And I also like to introduce you, Edwin Reyes, is our secretary from SLAMS. Edwin is a urologist in Peru. Thank you to be here, Edwin. For the next 30 minutes, we'll discuss a clinical case. There are no tricks here, just a common case from the day by day in the office of the urologist. So I'll make a couple of questions, and I stimulate our participants here, almost 100 attendees, to use Q&A button here to do your questions, and we'll try to answer them the most of live here and try to do some jobs. So next slide, please. So to start our discussion, we have a 65-year-old male, Caucasian, married with kids, no big deal, overweight with a BMI of 27. He has a myocardial infarction 3 years ago, mild sleep apnea, mild urinary symptoms. But the first of all, he comes here for fatigue, decreased libido, erectile dysfunction, and loss of muscle mass. He saw on the internet, he Googled it, and saw that he needs to look for an urologist, okay? So the IEF is 16, so the IPSS is 515. Next slide, please. And the cardiovascular history is important. So this infection is only 3 years ago, had an angioplasty with stent and ongoing medication with aspirin, statins, beta blockers, and the inhibitors of the enzyme. So this mild sleep apnea is also in treatment. So he's in CPAP right now, and it's stable. Next, please. And no other thromboembolic events, no family history of prostate cancer at the time. Ecdysm, it's a normal secondary sexual characteristics, normal testicular size, prostate about 40 cc's, no palpable nodes. So to start, I would like to ask for Andino. Thank you very much to be with here. And what's your first diagnosis approach with a man with complaining of libido? There's coming to your office. What you do first for him?
Yeah, absolutely. And thanks everyone for the opportunity to join and be a part of this ongoing collaboration with SLAMS, ISSM, and SMSNA. So you've provided a lot of the really important history. So the one thing that I'd be looking for here is, of course, as he has a prior testosterone level assessment. You know, we know that testosterone deficiency is not just a laboratory finding, but low testosterone levels with the associated symptoms. Certainly he has numerous symptoms that may be of concern, that low libido, low energy, and sleep apnea can contribute to energy, but it's already being treated. So I would talk about all those things and obtain those labs as a next step, but also I would spend a little bit of time talking to him about his erectile dysfunction. from the presentation we just heard, we know that we're not necessarily going to rely only on testosterone to address that symptom. And so this is a patient where I would also ask about have they had prior phosphodiesterase 5 inhibitor treatment, sildenafil, tadalafil. They have a cardiovascular history, and so I would double check verbally, are they do they have an active prescription for nitroglycerin or any other nitrate medication? And then lastly, they have LUTs. So if we do go down the route of phosphodiesterase inhibitor treatment, tadalafil may be a good option where we can get a 2-for-1 benefit in terms of urinary symptoms, sexual function, while we're getting additional information about testosterone deficiency and talking about treatment options.
Nice, very good. And to come everybody to the discussion here, I would like to ask Edwin. Edwin, do you think at this moment is some kind of importance we ask about the partnership, because we all know about the influence of the partnership in the most of sexual dysfunction. So how you deal with this in this kind of case?
Okay, thank you for the invitation to ISSM and SLAMS. Well, it's an important part, because sometimes if you find this kind of patients, the appreciation of symptoms, it's only by the male. The partner is important, because sometimes for the partner, it's a good performance. The feeling of symptoms, it's worse from the male more than the female. Sometimes it's the opposite. The female partner, or the partner is complaining about sexual dysfunction. Even the patient could have only a mild effect or even a light effect of erectile dysfunction or other symptoms. But in this patient, remember, we need to be careful about two main problems: the antecedent or the history of myocardial infarction and the sleep apnea. Why? Because we're planning to treat with testosterone. So it's important to know that this is bothering symptoms. If we're planning to treat with testosterone the symptoms, we need to ask for that.
Nice talk. And Mohit, to include you here now, and after that, going to the ongoing exams, we'll discuss this probably much better with the results of the blood work. But this is probably a man with metabolic syndrome, and we'll be concerned about that with the overweight, with the sleep apnea. So it's something else we can also be of concerning of this history, and something is missing here, or what can we treat about it?
Sure. Well, first, thank you very much for the invitation as well. It's a pleasure and honor to be here. And you bring a very important point. So you look at the causes for hypogonadism, obesity, metabolic syndrome, sleep apnea. Just because he has a diagnosis of sleep apnea and he's being treated for sleep apnea doesn't mean he's being treated appropriately. Many of these patients don't wear their mask. Sometimes they have the wrong setting, and the sleep apnea may not be optimized. So your point is, if you optimize the sleep apnea, if you lose weight, and I think weight loss is one of the best examples, there's a bi-directional relationship with weight loss and weight gain. If a man loses 10% of his body weight, 85 nanogram per deciliter increase in testosterone. If he loses 15% of his body weight, almost 250 nanogram per deciliter increase in testosterone, and it goes both ways. So, optimizing his diabetes, his weight, his sleep apnea, you may see a significant improvement in his serum testosterone levels. The only problem is many times it's not sustainable. It may gain the weight back. So that's one of the main issues. But we always like to start with lifestyle modification in conjunction with starting him on testosterone if it's low.
Fantastic. And so next slide, please. So we have the blood work, initial evaluation with total testosterone with 200, LH and FSH in the normal range, an SHBG 50, prolactin and estradiol with normal ranges, PSA 1.5, and hematocrit now for 42. And Juan, this profile, you think it's like he is, you imagine it would be any kind of different? You think it's missing something here? What's your concern is now with this workout?
No, this is great. This is exactly what I was looking at. I didn't mention out loud the hematocrit, getting that as a baseline, as Dr. Kara just mentioned. Sometimes someone thinks they're having the sleep apnea perfectly treated, but if you get that first hematocrit and you haven't even started any sort of therapy, and it's already at 52, 54, 57, that's someone that you're going to have to engage the sleep medicine team to make sure that their sleep apnea is better managed. I think the only other thing that I would have added on here and is get a hemoglobin A1C. We know he's obese, overweight. Sometimes people already have a diagnosis of prediabetes or diabetes, but I've been surprised in the last couple of years where I'm the one referring people to either primary care or endocrinologist because it just hasn't been checked recently. And so I take the opportunity of, if we're going to do the lab work, let's do a comprehensive evaluation and make sure that we're not missing anything that is going to affect their overall health, not only their urologic issues.
Fantastic. It's my mistake. I didn't put it here, but it's all normal about the glycemia and the H1C. So, Mohit, we can talk about the other hormones here, because we have a man with low libido, and we start to show up that there's some difference about the estradiol and the relationship about low libido with that. And what can we expect about this SHBG? Something we can really give care about that with this total testosterone with 200?
Yeah. So there's a couple of points you want to make. First of all, the PSA in this case is typically underestimated when the testosterone is below the saturation point. So when you normalize that T, the PSA may go up by 0.2 or 0.3. So it's not an accurate PSA. And so just something to keep in the back of your mind. It's interesting because, in patients who have obesity, SHBG is typically suppressed. His is on the higher end. So we would typically see a slightly lower SHBG in this case, but it is what it is. When you come to libido, we teach the residents, there are 4 hormones you have to remember. There's a very nice mnemonic, PET, P-E-T-T, prolactin, estradiol, thyroid, and testosterone. And so if he has a low libido, you're missing the TSH. You want to see what's his thyroid level, because that could be contributing to his low libido.
Fantastic. We have seen here a great increase of diagnosis in hyperthyroidism, so it's a great remember here. He's also has his normal range. So next, please, Edwin. Next, please again. And what about the LUTS concerns? Because this guy has something of the LUTS concerns. Do you do any other workout here with any other exams? You are concerned about it? We'll treat it anyway together. How are you concerned about BPH now?
Remember that almost 40 to 50% of patients with BPH come with some type of erectile dysfunction. So it's important to us in the history that kind of relation. Second, it's important to know if we need to treat the BPH, because it could have an enlarged prostate. But if the patient have no other symptoms, have no other different symptoms than nicturia that could show us to a problem with the BPH, could center the treatment, not center the treatment in the hypogonadal state and the erectile dysfunction. And as suggests Dr. Andino, the treat with the tadalafil that treat both of the problems could help us to give less medication and treat both of the problems. So I probably ask for a fluxometry, a study of flux. If we find an obstruction, we could add other kind of treatment. And if we find signs of urinary retention, even the size of the prostate, we need to start to find the problem, or start to treat the problem with PSA. But remember, we're finding here a patient with probably a metabolic problem. So remember that some patient with metabolic problems and diabetes have urinary tract symptoms related with metabolic problems. So it's important to define that with a simple test, a fluxometry and ultrasound, in order to evaluate if we need to treat the LUTS caused by BPH or not.
Leonardo, may I say one thing?
Oh, yes,
one
for
thing.
Sure, please.
So remember, in the Traverse trial was 5,200 patients. All patients received IPSS score, right? And they were followed for up to 4 years. And there was no significant increase of worsening of LUTS or worsening of urinary symptoms. But remember, they did exclude patients with severe LETs. So just remember that. They excluded patients with severe LETs. And I do believe that patients with severe LETs who are below the saturation point, when you put them on testosterone initially, you get the hypovolemic prostate getting to the euvolemic state. Some of them get a little worse. They can. And so if you have a man with a testosterone 150, severe LETs, he may get a little worse at the beginning. But if you treat that patient for longer and longer periods of time, after 12 months, those patients tend to have a significant improvement in urinary symptoms. So just be careful at the beginning with severe hypogonadism and large prostates.
Very good point. Very good. Remember it. Next, please. Mohit and Andino said about sleep apnea, and I would like to give Landon to the talk because he just published an amendment for the AUA guidelines after the Traverse results, and we wrote something, a point there about sleep apnea, no obstructive or sleep apnea. So, Landon, could you give us a talk about what the concerns we have to build with this sleep apnea in this patient?
Yeah, so it's definitely one of those controversial areas where there's not clear data on what's good or bad with it. The concern is that there's some data showing that if you start someone on testosterone who has untreated sleep apnea, particularly if they have severe sleep apnea, it may worsen the condition. No one knows why. It's thought to be a central neurological impact more than anything else. Some people thought it was a volume issue, a vascular volume type thing, but no one knows for sure. And so that led to, it didn't actually lead to a full statement in there, but to comment that, men with untreated severe sleep apnea should be treated before starting on testosterone therapy. The other issue is when you have untreated sleep apnea for a long period of time, erythrocytosis becomes a core issue. And so that can contribute to, you've got testosterone plus untreated sleep apnea. And then in some men, you treat the sleep apnea, suddenly they feel remarkably better. And so some of those symptoms that were driving you to do the testosterone in the first place may disappear. The challenge, as we all know, when you've had a guy who's untreated sleep apnea, you start him on treatment, he feels remarkably better for like 6 months, and then he feels bad again. So who knows why, but a lot of times you just get this bump in effect that goes away with time. So
nice. So in your practice today, Mohit, do you have this concerning about doing an investigation about the sleep apnea in the patients, or do you wait for starting testosterone replacement? What's your concernings?
Yeah, two very important points. We, as a group who prescribe testosterone, all of us listening on this call, we have the great opportunity of diagnosing occult sleep apnea. Because when you put a man on testosterone replacement therapy and you see these hematocrits go up very quickly, many times you can send them for a sleep study and you will find and diagnose occult sleep apnea. They don't have to be obese, that you can find it. So just don't forget that. If you're noticing that they're having to donate or phlebotomize, send them for the sleep study. But I do agree with Dr. Trost that, you have to be careful when you have someone who looks like they could have sleep apnea. You screen them for sleep apnea. If you don't treat that sleep apnea, you could potentially make the sleep apnea worse. Now, most of the earlier studies suggest that was seen in patients who are at higher levels. Some of the studies would show supraphysiologic levels were much more dangerous. It wasn't so much going from hypogonadal just to the mid-range. It was more in the supraphysiologic where most of the data had the concern.
Nice. I'll try to use some questions about the Q&A. Somebody asked here, should genetic studies such as SHBG repeat or CAJ repeats, then the androgen receptor, be used nowadays in the diagnosis or helping somehow in the hypogonadism management?
That's a really good question.
Good.
Yeah, and Dr. Kara, please add to this. I know there was a talk, I believe at the last two SMSNAs that have talked about the androgen receptor gene and how there's likely going to be testing in the future that may show some differentiated differences in expression, and that may be contributing as to, why do people with similar testosterone levels or similar raises in testosterone levels with treatment are responding symptomatically so different. From my understanding, at this point, it is not ready for clinical practice and clinical use, but it does seem like there's a lot of ongoing work in this space and really interesting preliminary findings. So I wouldn't be surprised if over the course of my career that becomes more of a concept or a targeted treatment option as opposed to just going off of 300 nanograms per deciliter is the same for everyone, regardless of age, comorbidities, etc.
And
I agree with Dr.
to keep continuous to Mo, just to keep a bridge. Could this also get an answer about young patients with high gas HPG or young patients with not responding to any treatments we do and the same symptoms? Could be the same idea?
Yeah, but I really think that Dr. Andino is right. Remember that, so every patient, almost every patient that comes to my clinic, we take their blood and we send it for CAG repeat in our lab, every patient, and we bank it. And so what we're doing is many patients who have very insensitive receptors, means long CAG repeats, greater than 27, tend to need more testosterone to have symptomatic improvement. Many patients who have very sensitive receptors don't need as much testosterone to see symptomatic improvement. We've also shown this in women as well. So everyone on this call, we all have our own number where we feel good and where we feel bad. It can't have one number for everybody. And that has to do with our genetics and CAG repeats. And I think that's part of it. The other part of it is what you're describing is the SHBG, because the reality is that the body really cares only about the free T. It's the best symptom, best correlated with symptoms. So a patient could have a normal testosterone of 450, but a very high SHBG, free T will be low, and that could explain why he has symptoms as well. So it's many things you got to look at to see why someone's not responding.
Fantastic. And next, please.
I want to discuss something. I want to discuss some things about Dr. Kara told about the value of the testosterone and severe BPH. How many patients do you see that have severe BPH with low testosterone below 150 nanogram per deciliter and need to be treated because of the great symptoms? What do you treat first? The problem of testosterone and weight, how the patient responds to treat the BPH, or treat both at the same time and try to avoid some complications about that. Personally, yeah. I do the second one. I try to, it's not so many patients that comes to with very, very low testosterone with severe BPH. In that case, I try to treat it both. But what is the way that the panel treat that kind of patients?
I would treat the BPH first if he had severe BPH and very low testosterone. So the 150 and severe BPH, I would treat the BPH first. But I would still be concerned if someone had a T of 200, 220. He's still below the saturation point. So he's still going to get a bump, you know? But you're right. But I would definitely want to treat the BPH first, then the T. And I would tell him, when I start the T, your urinary symptoms may get a little worse for the first 3 months. And if you look at the graph, and then it's kind of stabilizes after the first 3 months. It may get worse for the first 3 months. Just want to prepare you. It may not. But if it does, over time, it will stabilize and get better. And that's how I would counsel them.
Fantastic. So next slide, please. So Edwin, in this case, so we have this guy with low testosterone and very low levels. It's a LUTS, but it's not severe. It's a mild LUTS and something like that, and no big deal. And we have a bunch of options of the treatment. Okay, there's not a correct answer for that. We can start with we can follow AUA guidelines or EAU guidelines or real life guidelines, and we can start with something else. But what's your practice here for these patients? What's your concerns? What do you do first here?
Okay, first of all, they have two main concerns, as I told you in my first intervention. The problem of obstructive sleep apnea, but it's treated with CPAP. It's stable, so it's not a problem to start testosterone. And we have no problems with BPH. Why? Because it's stable. It's a mild BPH. And we could treat it with PD5 inhibitor like tadalafil to treat both of the problems. So I like to start with testosterone directly. Okay, remember, even if patient have 65 years old, one of the main things to start testosterone is asking the patient if we want to have kids or not by now. Sometimes here in Latin America, there could have a new partner and want to have kids. And it's important to, before to start testosterone, ask the patient if they want to have kids or not. If not, And in this patient it's willing to treat with testosterone, I started with testosterone. And as I told you, with the treatment of the BPH with tadalafil in that case, I start a combination with testosterone. In my country, is not available most of the treatment that have in other countries. It's only gel and monthly injection. There is not available a 3 months injection. And even if we have pellets, it's not from the industry and it's not approved. So we start with an injection of monthly testosterone, the short acting testosterone, and with PD tadalafil. That's my way to approach to this patient.
Fantastic. And how about lifestyle modification? We know Dr. Mo said that we all know that we need to incentivate that, but most of them we cannot start it for many reasons. And how can we approach this with the patient? Should it be different, something different like Edwin, or how can you conduce it?
I can jump in. Dr. Kara highlighted, kind of a chicken or the egg situation where there's really this bi-directional relationship. And so in many ways, in addition to everything Dr. Reyes just said, I would make sure that part of our discussion that we have is that, okay, we're going to try to get the testosterone levels back into normal range. But in addition, you have all these other metabolic syndrome in the background, elevated BMI, et cetera. And so that's a patient that I encourage, say, look, as you start to feel better, you have more energy, you just feel more motivated, et cetera. Make sure that we're watching our portions, that we're cutting down. Most plates in the United States can feed 2 to 3 people. So I highlight that. I talk to patients, we don't need to do a fancy diet, but let's just start with looking at portion control. Let's talk about cardiovascular exercise. People always think about, I just need to go to the gym and just stand in one spot and pump iron, but highlighting that cardiovascular disease is still the #1 killer of men in the US and in most of the world. Cardiovascular exercise is really important, and that they're going to get a better response. They're going to feel better overall if we're not relying on the medication alone, but really combining this lifestyle modification with medication, with addressing the quality of life improvements that are going to get from making the ED and the LUTs better.
Your option here will be a combination. We start first with testosterone replacement. What do you do?
I think I would definitely be a combination. It would be lifestyle, tadalafil to address both the lower urinary tract symptoms and the erectile dysfunction. And exactly as Dr. Regis said, if this is a patient that's not interested in future fertility, they already have children, and if they don't have a new partner, younger partner, et cetera, I'll talk to them about the options of different testosterone modalities and then just make a shared decision. Maybe they like a daily gel that they apply every morning because they travel a lot, et cetera, or they may like the schedule of a once a week subcutaneous injection, easier for them to put on their calendar. And so we'll come to that decision together.
That's it. Mo, it's just a quick comment because there are several questions about here. In what case would you prescribe or clomiphene or aromatase inhibitors for concerning about obesity or fertility? What is your point of view of it?
There's only 3 options if you want to prescribe a medication to raise endogenous testosterone. It can be clomiphene citrate, HCG, or aromatase inhibitors. You want to look at the LH and the FSH. If the LH and FSH are elevated, then really the HCG and the clomiphene citrate are not going to be very effective. In that case, you'd want to use an aromatase inhibitor. Be careful by using an aromatase inhibitor because it can long-term use can lead to osteoporosis. And quite frankly, men need estradiol for libido, and you're just shutting it down. Clomiphene citrate's good. It also does raise. It's a pill. It's cheap. It's easy. But 40% of men who take clomiphene citrate will have very little benefit in sexual function because it blocks the estrogen receptors. And so they say, I know my testosterone is 800, but I don't feel like an 800. You put the same man on exogenous testosterone, you get to 800. He says, I feel like an 800. So I think that's very helpful. So we use these medications because all of them preserve fertility. Quite frankly, my favorite would really be HCG, but it's expensive and it's invasive.
Yeah. We have a question here from Djalma Ribeiro Costa. Thank you, Djalma. Would you investigate now osteoporosis in this clinical scenario? It would be helpful to do some bone scan. I think, Mo, you can answer that.
I do. I think it's important if you have someone who has low testosterone, older age, risk factors for like low impact fractures, risk factors for osteoporosis to get a DEXA scan. In the US, Medicare will cover it every 2 years. So you can get a DEXA scan, treat them on testosterone and get another one in 2 years. But I do think it's helpful, particularly for someone you have concern that they may be an increased risk for bone fracture.
Fantastic. So next slide, please. Can we have the next slide? Okay. So as we follow, as you do here, and like the AUA and the AIU guidelines, so the DEXA scan is normal, no regarding about bone health this time. And we start about using long-acting testosterone because he also should better because, I mean, we have a big deal to talk with patients here about using testosterone gels or testosterone injections. And Edwin says something about how is this talk in Latin America, especially in Peru or like in Brazil. Juan, how you can discuss the many options you have about doing testosterone replacement with your patients, since you have all your very options and you have things the other ones there in the United States. So how can we discuss the very options you have with the patients?
Yeah, it's something that you have to take in the local and international guidelines, and you have to apply it to your local context. So you have to know what is available. And for example, in the United States, here in LA, a little bit of it is getting a sense of, depending on the different forms of insurance. Right now, I'm in our community clinic in South LA. I see primarily Medi-Cal patients here. So it's a state-based insurance, a very different scenario in terms of what's going to be covered by insurance as opposed to someone who's privately insured through their work or Medicare. It can be a little bit overwhelming because there are so many options. And so in many ways, I've generated some pamphlets and handouts that some patients will receive even before our consultation. So they'll start learning about some of the kind of first line options that are covered by most insurances. And then I tailor that during the appointment. Once we have symptoms, 2 testosterone levels under 300 nanograms per deciliter, that's when I really sit down and talk about, okay, there's the gel, there's the injection, et cetera. And in some ways we're biased, right? But what are the recent things that patients have struggled with or the feedback from patients? So a lot of our patients, you know, I talk to them about gels, weekly injections. There is a self-injector in the United States, Xiasted. And so that is an option for some of our patients who have issues with injections or needles. But you have to create a system that works for you, for your clinic, and for your practice so that you can both inform and educate patients, but make sure that they're getting the information of what's going to be accessible to them. Because people can get frustrated if they learn about everything and then they find out their insurance doesn't cover X, Y, or Z.
Very good point of view. And I think one of the things we have to discuss with the patient is also the evolution about the treatment. Yeah, how we respond about that, what do we expect, and these expectations aligned would be very important. So, Edwin, how will be the follow-up for this patient right now to explain about the improvement of the symptoms, how blood work will work, and how many times you come to the office? How do it work now?
I check it out, first of all, every 2 or 3 months in order to evaluate the PSA, the amount of testosterone, and the hematocrit, okay? Because we could have some side effects. And I follow up the symptoms. If the patient does not improve, for example, the symptoms of libido. Remember that the libido, as the Dr. Kara talked to us, it's depend of the estrogen. So we need to elevate the level of the estrogen through the level of the testosterone. So levels are about 700 or 800 and measure estrogens. If the patient does not respond to the initial treatment with testosterone, it's important. We need to elevate the estrogen estradiol level above 15 picograms per milliliter in order to see if these patients have response or not. And we try to treat it. I started with gels. Okay, and we get some of the stable treatment with gel. I pass to the injection. First of all, it's to treat the problem. even 3, 6 to 12 months if we have some problems with the levels of testosterone or the other symptoms or the side effects. We could regulate it with gels. That's the first approach to this patient.
Fantastic. So next slide, please. After the follow-up, 4-month follow-up of this patient, he has improved energy, libido, and even muscle mass doing his exercises. No significant improvement yet in ED because we use it only testosterone, and sleep apnea, no worsening, LUTS improvements a little. And the results of testosterone gets really high, so 790 grams, and hematocrit up to 50, and PSA, its highest level lies 1.9. So, Mohit, according to a question here from Luis Otavio, thank you for your question. And some societies say we have the maximum tolerated hematocrit for 50, some for 52, for 54. And what can we concern about this regarding even about reverse results, about hematocrit levels we tolerate to be the highest?
Yeah, there is a theoretical cardiovascular risk at 54, and I want to stress a theoretical risk. And so many guidelines will say, for AUA guidelines, say if someone has a 50, you wouldn't start them on testosterone replacement therapy. American Family Practitioners say 48. But in this case, this is different. He's on testosterone and it went up to 50. And so I typically in my practice will have patients donate at 51 because I don't want to get to 54. I want some buffer. So I want to drop it below. That's number one. You have the option of switching the modality because the injectables have a high rate of erythrocytosis. If you switch them to a gel or an oral, you'll drop the erythrocytosis. So that may be helpful as well. But in this case, I'm not ready to donate yet. I just have the discussion with him. But I am worried about the management of his sleep apnea. And I just want to make sure that it's actually being adequately treated.
Fantastic. And when about the PSA, the previous PSA was 1.5 and now 1.9. It's already concerning of you this increasing or is not yet? How do you
it's appropriate
movement about that? Because
that's what I was going to say. Yeah, no, that's perfect. It's such an important thing to bring up. Dr. Kara mentioned it, and there's multiple studies that quote about a 0.3 point increase in the PSA if someone is below the saturation point and you get them to eugonadal levels. And so it's appropriate. It's one of the things that I have in my testosterone handout, but I certainly try to bring it up to patients directly too, especially if they have a personal or family history, or they kind of got incepted by someone well-meaning who said, well, the reason I'm not giving you testosterone is that, it's going to make your PSA go up, which is then it's going to make you have prostate cancer. So it is really important that expectation management is not only symptoms and total testosterone and hematocrit that we're going to follow, but also anybody over 40 or 45, I mentioned that PSA aspect. And if they don't already have a baseline PSA, I try to obtain that before testosterone therapy and after, and reassure them that this is okay. We're going to continue to follow it just like any other man according to the AUA testosterone guidelines.
Fantastic. So next slide, please. So as you said before, we started with daily tadalafil. Next slide. And he had improved in erectile function with daily tadalafil together with the testosterone. But now, 6 months after that, we have an increase in the hematocrit with 54 and an increase in the PSA with 2.1. So, Edwin, what to do now? We have reached the 54, and what to do with this hematocrit now?
Usually here in Peru, we have some local issues about hematocrit. Remember that we have high altitude residents with hematocrit that is starting 50 or 54. So the practical issue, even we know that below 54 and with above 54 with symptoms, the hematologists recommend a phlebotomy. Okay, but if we have below 54 and we have no symptoms, we could observe this patient. And sometimes, because of some related issues about working, some people that have with testosterone levels of hematocrit at 60 and the the mining enterprise does not allow the people to give a phlebotomy, we could have some indication that conservative measures like restrict diet at sometimes of some other measures instead of phlebotomy. But in my cases, if the patient have symptoms of erythrocytemia, I recommend to go to the hematologist, and he usually recommend phlebotomy. But the number of the reach of the goal is 45. So we have some concerns about it because they have some. They told me that they said that this is increased risk of problems with a thrombosis. And in this case, the patient have some myocardial infarction. So I recommend to this patient, in that case, in that particular case, a phlebotomy if we have the chance to do it. But remember, here in Peru, some people that lives in high altitude could manage this problem only with conservative measures.
So well remembered by Edwin, this thing about the right levels attitude. But remember, this patient had a sleep apnea, his metabolic syndrome, is overweight. He had the past of infarction, and we have this hematocrit 54. So including here, we have a question or an observation by Dr. Hackett from London. We can use also an option to increase the interval between the injections, but again, we have to be concerned about this hematocrit because of the other comorbidities of this patient. So, Mohit, how do you manage this patient in the United States in this moment?
Well, I mean, obviously, in this case, I think we brought this up, but I would phlebotomize. I think that was brought up earlier, just to make sure that this patient brings his hematocrit lower. I would stop the testosterone supplementation. I actually cut off all the prescriptions, because sometimes you tell them to phlebotomize. They say they will, and they don't. And then they come back, and the hematocrit is now 58. So I stop all the prescriptions. And I say, until I see that the hematocrit is below 48, then we can start again. So I think that would make a lot of sense.
And could you tell me something about Juan? Can you treat the patient? One of the options is changing the to gels, maybe, but we know that it's difficult that the patients can change from injection to gel. It's easier to change from gels to injections, but do you think it can be an option to do this combination of changing
so what you can do, remember that the erythrocytosis is about the spiking. So the more you spike, the greater the risk. So if you use injections, let's say you use a weekly injection, you can split it and use it twice a week, and that'll drop the erythrocytosis rate. I think the worst thing you do, some people give 200 milligrams every 2 weeks. That has the highest rate. 100 milligrams every week, a little bit lower. 50 milligrams twice a week, better. So you're same milligrams, but you're dropping the number of, increasing the number of times you give it over 2 weeks. That will decrease the erythrocytosis rate. So you're right. Some men who are on injections say, I don't want to stop. I like my injection. I say, okay, then let's change the amount of times that you do it. I even have patients in my practice that do microdosing every day. They just divide it by 7 and sub-Q once a morning, and it will keep the erythrocytosis down.
Nice. Juan, and what now? PSA goes to 2.1. It's a little higher than before.
Yeah, that one definitely caught my attention, because I think I would have expected the 0.3, 0.4 increase early on, but 6 months later to see it continuing to elevate. If this person's in the clinic, I'm going to offer a prostate exam and make sure there's not a nodule or lump or bump, anything that would feel abnormal in the prostate. And also, I'm probably not going to wait 6 months or a year to check the PSA again. This may be someone that I say, even before our next appointment, let me order you a PSA, and in maybe 6 weeks, 8 weeks, 10 weeks, keep an eye on it to make sure that we're not just continuously going up.
Fantastic. So next slide, please. We have discussed these options about management of the elevated hematocrit, and probably we have to do the combination of all these sometimes. Next slide, please. and the patient should opted for therapeutic phlebotomy, and we try to switch to testosterone gel. We convince him to switch it to gel, and here we don't need to prescribe testosterone gel, so he comes to testosterone gel, gets well, and go home. And next slide, please. I'll come back to the office 1 year follow-up. So he continues with gel. He's quite well with this, with no symptoms, no other effects, no worsening of apnea, continued improvement with LUTs. Total testosterone gets a little lower now. The hematocrit really gets lower, but we have the continuous increasing of the PSA now. So Edwin, how do you manage this patient in Peru now?
Okay, we see a continuing increasing of the PSA. So we need to evaluate the possibility of some other problems instead of PPH. So my plan is digital rectal examination, and in the first case, suggest an MRI in order to evaluate if we have some findings that leads to take a early biopsy or could observe it. But in this case, the PSA is rising over 3 months, so we need to take some measures about it, and MRI and the possibility of suggesting a biopsy to evaluate the case.
Fantastic, just like Juan said before. So next slide, please. He actually had a MRI with Pirates 3 and a biopsy with ISSM prostate cancer. And Landon, there are a question here in the Q&A, and you say, I don't know, I can't remember if you say that, but saying testosterone leads to prostate cancer, do you mean it makes appear, being detected, or grow an existing one, but not causing per se? It's just like this case. You think he had already a prostate cancer. How can we explain that we do not cause this prostate cancer using testosterone?
Yeah, and I mentioned that just in the conclusions, just because some people will go so far, on the side of things to say, oh, testosterone does not cause prostate cancer at all. And what they're meaning to say is, if I supplement someone with testosterone, I'm not necessarily going to increase their risk of prostate cancer. But in reality, we know that testosterone is the driver for prostate cancer. I mean, testosterone is a driver for developing a prostate. So no question, it is the mechanism by which these things develop. The question is, does it cause or lead to prostate cancer? Now, in this particular guy's case, the argument would be, why even get the repeat PSA? Like, you get the baseline one, but why even get a repeat? I mean, he's 65, he's had an MI 3 years ago, he's high, he's, comorbid conditions are really high. And so there'd be an argument for saying, quit checking, don't look. And because, like in this case, you probably detected this man's prostate cancer, which has been there forever. And even the AUA guidelines on it say PSA velocity alone should not be a driver for biopsy, imaging, or anything along those lines. So, but once you've detected it, now it becomes something that, how much of a psychological burden is it for him, and where do you go from there?
Fantastic. I would like to bring Dr. Sidney to the discussion now, because I will ask for some points that are different in many countries. So if Dr. De Glinas is still with us, I'd like him to join us. Okay, thank you. Next slide, please. So we have some considerations now. We have to reevaluate the need for testosterone right now, I think, because we have a patient with cancer, with prostate cancer. And regarding the risk and benefits or discontinuing TRT, eventually this patient is a candidate for active surveillance. So how to follow up after that? So Dr. Sidney, in Brazil now, we have most concerning of patients being able to accept this active surveillance into maintaining testosterone replacement. How do you feel comfortable, and how do you manage this patient now to indicate something?
I think this is a question of discussion with the patient. The patient should understand the risk, and if he's doing very well with the testosterone replacement, and maybe we can go on with the active surveillance, because it's probably it's a non-significant tumor. So maybe you can think that maybe if he has his own testosterone in this level, we won't keep, we won't do anything. So you go on active surveillance. I think the key point is how the patient understands the problem. We cannot go on and don't. If now you give gel for him, and he does not need a prescription, so maybe he can go away and never come back. So he needs to understand, and active surveillance, I think it's a good option for him.
And how is your approach with him about sexual function? Because if we come with him with a surgery, we'll have an impact in sexual function and in main effects about the inhibitors of testosterone 5. So how is about your talk about sexual function right now?
For after surgery?
Yeah, yes, because we have to decide some treatment to choose after active surveillance or surgery.
It's any other patient with prostate cancer. You need to talk about the consequence of the surgery, the erectile function, the rehabilitation, the loss of ejaculation. I think it's you go on of any other patient with prostate cancer.
Fantastic. So, Mohit, how you manage these patients in USA? Any difference? Something regarding of this?
Yeah, I agree with Sydney. First of all, you have to counsel this patient because we don't have any large randomized placebo-controlled trials saying that active surveillance is safe. But I want you to think about something. You know that the risk of occult prostate cancer in the community is 1 in 6, right? We know that for a fact. And you look at all the studies that treat men with testosterone. The studies have not shown that men treated with testosterone have a higher risk of prostate cancer than those being not treated with testosterone. For example, in the Traverse trial, 5,200 patients, over 2,500 of them were treated with testosterone. You know there were many patients in that trial that had prostate cancer, and they just never lit up, right? So this is the best example of an active surveillance study. Limitation of the Traverse was it wasn't long-term, so that's another issue. So long-term. But the reality is that we are all, everyone on this call is treating men with active prostate cancer with testosterone. We all are doing it. They're just not lighting up. And so I think that, again, it really is a deep discussion. You should just have the risk benefits. You don't want to tell them, hey, this is the safest thing. No worries. Don't worry about it. You really have to say, look, we don't have any large randomized placebo-controlled trials, but I would treat him on active surveillance with counseling.
Fantastic. Juan, let's imagine once he chooses to follow up with active surveillance now, would you change anything about the follow-up and the active surveillance and more earlier biopsies, following up with PSA? How you imagine this?
No, thank you. I'll combine. It's basically a combination of what Dr. Guida and Dr. Kara have said, that now, given that counseling, and as long as this is not someone who's just laying there awake at night thinking about their PSA level, if they're comfortable with the management and follow-up, then I would treat them just like any other active surveillance patient. And that protocol is going to vary a little bit by institution, by hospital system, et cetera, but it'll be a combination of DRE, digital rectal exam, PSA, repeat MRI imaging. It's nice that we have a baseline with a PIRADS lesion. If that changes in the future, that's going to be a target to look at, and certainly a prostate biopsy. Confirmatory testing is a really important part of the active surveillance protocol, and you can't go off of PSA and DRE alone.
Fantastic. Edwin, in Peru, you have patients well advised with active surveillance. They most have to continue with active surveillance, or they get more careful about that and choose to be in active treatment with surgery or radiotherapy?
Here in Peru, the active surveillance it's quite difficult because there is no protocols here to go there. So the patients know that if I have prostate cancer, I need to be treated. So it's quite difficult to go with a patient with some other treatments that not intervention. But some people, if you try to explain the problem, get active surveillance, and even some of them with active surveillance maintain the treatment of the testosterone, but they know that the possibility of increase the risk of not having treatment of prostate cancer, but prefer the well-being, that feeling the treatment of testosterone, and evaluate the risk of not be treated by prostate cancer. Here in Peru, the testosterone, advertising is not for prostate cancer. So even a patient like that with a Gleason 3+3/6 with the possibility of active surveillance, they not choose the possibility. So we need to discuss within the treatment of the prostate cancer. Unfortunately, we try to explain the patients, discuss the patient the treatment, but most of them that not choose this option.
Fantastic. Juan, you have raised your hand. You have any comments?
I just wanted to say one last thing before you go on, Dr. Lopes. If you look in the chat, everyone, our host just shared a link. So this was a abstract that got a lot of attention during the AUA this last year. It was Dr. Jim Hu, who's a urologic oncologist, so prostate cancer surgeon, and they did a large retrospective study of patients on active surveillance who received testosterone therapy. Not a randomized clinical trial, so we still have to have that, in the conversation with patients. But this large study really kind of reiterated some of previous findings that there did not seem to be a strong association or increased risk of developing clinically significant or worsening prostate cancer outcomes. So again, not perfect data, but just something that was recently published in European Urology. And it's helpful for this discussion of highlighting that, low-risk prostate cancer unlikely to hurt you unless it progresses. And while we don't have randomized clinical trials, at least we have some data to support that it is safe to treat it just like any other low-risk prostate cancer with active surveillance.
Fantastic. Good remember. Next slide, please. We get to the end of our discussion now, and so I will have a couple of slides. We follow up with active surveillance for this patient and start monitoring every 3 to 6 months with the PSA and establish a need of any other MRI after that, and continuous evaluation of the symptoms. And we have a multidisciplinary team consultations with the clinical oncology here to get more safety in the follow-up of this patient. So next slide, please. We have a conclusion and key points of this discussion. Monitoring these patients, it's important. We see that about regular follow-up with hematocrit and PSA levels. Probably we diagnosed this cancer prostate earlier because of the TRT replacement. So it's important to do this. We have to get effects to management the adverse effects because of we have the hematocrit, mainly in these patients, about the erythrocytosis. Vigilant monitoring about cancer surveillance, it's important. So we have still to do education, even for patients, even for now, for us doctors to do this. So this webinar is important for that. And we have to still to manage these patients about cardiovascular risks. We have a couple of questions here just after we finish, before we finish here. When you stop, I think it's like that. When you stop TRT, when you replacement in a patient after radical prostatectomy, I think the question is, he did a prostatectomy, you start TRT, and then when you stop it, you see a raised level of PSA. Is any concerns about that? I think, Mo, you can answer that.
Yeah, that's an easier question because that's after a radical prostatectomy. So they have an undetectable PSA. So when the PSA starts going up, obviously you worry about a biochemical recurrence and you treat them just like you would anybody else who have a biochemical recurrence, start by imaging, right? It's the patient who has had radiation, XRT and ADT, and you start them on T and the PSA goes up because it's supposed to go up. Then you have to stomach it till it plateaus. That's a different that's a much more challenging case, but post-radical prostatectomy would be easy. You treat them just like anyone else who had a recurrence.
Nice. Edwin commented about doing the phlebotomy, but we here in Brazil always recommend to a center, for a hematology center, to do that. Do you have in the USA, Juan, any protocols or algorithms available to phlebotomy about recurrent schedule, frequency of donation, how much volume you take it? Do you have any guidance about that?
No, that's a good question. And we also lean heavily on kind of this multidisciplinary care and making sure that we engage our hematologists, oncologists. Sometimes there's delays in getting access, or there have been patients who have just done, blood drives and they've been able to donate to keep below that 52, 51% level that Dr. Kara mentioned. But, that's a good point for me. I should probably reach out to our hemonc team and check in with them to see exactly, how much are they drawing? When do they recommend rechecking? I, at minimum, if I haven't seen anything in their chart, will try to check in again within 2 to 3 months to make sure that they've done it, that number has come down. But I probably need to learn from Dr. Kara, who's been doing this for a while, and just be a little bit braver about pausing therapy until I get that confirmation, because I think I'm letting my young face give away to patients requesting their medication even before that lab has come back, and me giving in a little bit too easily.
Yeah, I agree with Juan. The protocol we use, and we've been using it for now 15 years, is you donate 1 pint, you wait a week, you donate another pint. So 2 pints separated by a week. And then after a week, we check the hematocrit. It should have come down. And if we need to donate a 3rd pint, whatever it takes, but each pint is separated by a week. And then in the United States, a patient does not need a prescription to donate every 2 months. But let's say I need to have them donate more frequently. I can write an order for a therapeutic phlebotomy. They can take the blood and throw it away. At any hospital, they have to take the order, take the blood and throw it away. If it becomes a problem, we tell patients pick odd or even month, your choice. And if it's every even month, you'll donate every 2 months. If it's every odd month, you'll donate every odd. This way, we're being proactive, not reactive. I don't like to call the patient and say, look, your hematocrit's 55, you got to go in. Just donate every 2 months and we should have no problem.
Fantastic. We get to the end of this webinar, so I'd like to thank everybody for participating here. It was such a great discussion with such hot topics on testosterone replacement, and I want to reassure that this webinar will be on demand, so everybody can access after that, so can listen again and again of these experts about testosterone replacement. I would like to invite everybody again to join us in Rio de Janeiro for the next World Meeting of Sexual Medicine. It would be a pleasure to have you all here. It will be sunny days, so you can join even about scientific and can enjoy the beach too. So it would be a nice pleasure to do that. So I'd like to reinforce again the very thankful I am to moderate this webinar with ISSM and SLAMS, and we'll pass to the coordination for the ending of that. Thank you, everybody. Good night.
Thank you.
Good night, everyone. Thank you.
Thank you. Thank you.
Bye.
Thank you.